Here in America, of course, we have a real push for the transparency of quality results, transparency of physician and payments by medical device companies, et cetera, et cetera. What kind of transparency is going on in the UK with regard to quality results, for example? The reporting you had mentioned, how are you doing that?
I suppose the first bit is, for the first time ever in the United Kingdom, chief executives have now got to report publicly. Effectively, it's the board who've got to report publicly on the quality of services that they offer. And there will be certain elements of those quality reports that everybody will need to report on. So, for example, our hospital-acquired infection rates, I think, will be something that will be mandatory and everybody will need to report and make public. Over and above that, what we've committed to in the North West is really, with our advancing quality work, which includes the clinical effectiveness data, the patient-reported outcome and patient experience, is to put all of that into the public domain and try and do that in a way which is accessible to the public rather than some scientific sort of decimal place, 5 decimal places. Is actually to be very clear about the rates at which we're getting the right results and the right outcomes. So all that being in the public domain, and that would be quite exciting, because for the first time, our population is quite a deprived population, and they've probably on occasion been expected to be very grateful for what they've had in the past, and now we're upping that and we're saying, no, you should expect to be able to get the best results. And if your hospital or if your primary care service isn't providing that, you can see how others are getting it, and you should be demanding more of our services.
I actually absolutely support that in terms of transparency with the public. I think this is an area where, I don't know about this country, but in the UK we've not been that open about markers or measures of quality of service. So I think it's very simple that we ought to state at the front end of the year the things that we want to improve, and then report at the back end of the year whether that improvement's actually taken place. So in the quality accounts that Mike's spoken of, I think that's a mechanism for doing that, as well as having some of this other published data. And as we were talking about earlier, one of the things that we've been very keen to do is to make the public aware of what we're trying to achieve and change and improve. So when we applied the IHI's global trigger tool, we discovered that we were harming patients at a rate of about 850 a month, full range of harm, some tiny amount that's catastrophic, a lot of it was very marginal. However, it was all harmful activity that shouldn't be taking place, and we put that into the public domain and have spoken locally about that level of harm and what we're going to be doing to address that. So I think that the public are going to start to understand and demand change from hospitals, and you get that by being open and honest with them.
What do you see now for the future? What projects do you look ahead towards?
Well, for us, we're just at the beginning really of this journey, and so this is our first year of using the HQID indicators, and we're starting to see some interesting results. That now is a catalyst for real change, and I think the vision that we hold out is that we'll get a real grip on the sort of quality in our secondary care, our hospital services. We can align that with our quality indicators for primary care, and if we can add then that last community dimension, we'll be able to really describe quality for the whole patient pathway. And the importance of that is that you can then start putting the finances and the price of care in the right places to incentivise and reward people who prevent deterioration in their health. So it really gets the health system genuinely being a health system rather than being funded to be a sickness service. So that's part of our prize, and we're really excited about that. But it's maybe 2-3 years off before we can get near that. And I know that some of our providers are really now sort of motoring and getting together and trying to get a best-in-class group who can really take that journey and deliver the reality of my rhetoric, their reality.
I think that's right. There's quite a number of us now in the English National Health Service really interested in finding out how we do this, and we can either decide to do this on our own or come together and understand what may work in each of our different contexts. So we're looking not only in the northwest but also nationally about how we can organise this activity for people to come together and learn and share together. And we're working with Premier to try and give that some shape in the UK at the moment. I think the other area, as Mike suggested, is that in the English National Health Service we've an opportunity to do something different in terms of how patients flow into and out of hospital, into primary care and community-based services, and look at how we can redesign and get improvement in that redesign across the continuum of care, and that will be a challenge for us all.
Any last words?
Just to say, we've been really excited about working with Premier, and it would be wrong for us not to say something about that. I mean, it's a great organisation. We're getting real synergy, and we enjoy everything we do with you. So thank you very much.
Thank you.
It's a very good ending. Likewise.
Thank you.